Half of what you think you know about chronic pain and spine health is wrong. Let's talk about learning some useful strategies and discarding some old, outdated concepts. First of all, at a fundamental level, we are electrical and chemical beings. When we bang our elbow, pain gets transmitted from the point of injury all the way up to our brain, which perceives that pain. Or said more technically, pain signals get transmitted up the ulnar nerve to the brachial plexus, up the spinal cord, to the thalamus, and then to higher centers in the brain. These pain signals are transmitted through very fast electrical and chemical reactions through numerous pathways. These complex pathways can either be amplified or diminished by nervous system pathways. Dealing with chronic pain often involves learning how to recruit these powerful pathways and a neurological process called neuroplasticity. Has anyone ever had a problem with their computer? Most commonly, it isn't a problem like the one in the bottom right corner where the circuit board is fractured into pieces. No one can imagine that computer functioning normally. Usually we encounter a more subtle issue like a software problem, such as with a computer virus, or too many running programs that clog the processing power. Human beings are not that different. One key encouraging fact, though, is that even with severely affected hardware, our software can potentially keep us functioning at very high levels. Here we have an MRI side view of the lumbar spine. The MRI on the right shows numerous discs that are significantly degenerated and belongs to a triathlete whose back goes out only once or twice a year for a few days, and then he gets back to all his normal activities. The nearly normal MRI on the left is that of a person with intractable pain that hasn't responded to numerous medications, and it bothers her so much that she can't go to the mall, much less exercise. Here we have a case of bad hardware but functioning well, and good hardware but functioning poorly. Here's another case. The hip x-ray on the right shows severe bone-on-bone osteoarthritis with significant deformity. He's able to golf 18 holes and conduct business in a busy company. The x-ray on the left is that of a patient who has a limited ability to go shopping and enjoy a night out with friends. Again, we see bad hardware and functioning well, and good hardware and functioning badly. Now, there is numerous reasons that can account for these discrepancies. Patients in this situation commonly will be extremely frustrated, going from doctor to doctor, getting study after study, and no firm answers or treatment solutions. Regardless of the problem you're facing, you owe it to yourself to make the best of it and live as full life as you can. Knowledge about the truth regarding chronic pain is the key. Welcome to Zach and Diana's group fitness program for patients with chronic pain. My name is Zach Isaac, and I'm a physical medicine, rehabilitation, spine, and pain care specialist. I've been in practice for over 13 years. I'm an assistant professor at Harvard Medical School. I'm chief of the Division of Spine Care and Pain Management at Spaulding Rehabilitation Hospital, and associate chief of physical medicine rehabilitation at Brigham and Women's Hospital. I see patients from all over the world and consult routinely as a second opinion specialist for complex and refractory cases. I'd like to share with you my best understanding of this common and challenging clinical problem of chronic pain and the strategies that we have used to make progress where patients have struggled before. When it comes to pain, there's no shortage of structures that can be a primary pain generator. The intervertebral disc can degenerate and create mechanical back pain, and the inner nucleus can herniate outward, which kicks off a chemical cascade of inflammatory mediators that can injure the spinal nerve root and cause pain. There's a nerve structure called the dorsal root ganglion, which is where the sensory cell body lives, and is believed to be a potential area for pain regulation. The facet joint is a very small joint that can develop osteoarthritis and can generate chronic low back pain. Various ligaments can become injured and strained. Various muscles can be in chronic spasms and develop sprains. The blood flow to the spinal nerve root and spinal cord can diminish due to compression from arthritic structures. While it is very easy to identify these problems on MRI imaging studies, many people, approximately half depending on the age group, have these findings without having any pain whatsoever. So it becomes challenging to figure out what is the cause of pain when most people have these aging and genetically programmed changes anyway. This is an image of the facet joint demonstrating arthritic changes. Here we have ligaments that can become injured, muscles that can go into chronic spasm, and blood flow to the nerve root and the plexus. Pain can be classified also by how long it has been going on. Acute pain is when pain has been going on for less than 4 weeks or maximum 12 weeks. Chronic pain is when symptoms linger beyond 3 months. Most acute pain improves. Many conditions that cause chronic pain continue to hurt even after tissue healing has occurred. Pain can also be classified based on whether there is tissue damage occurring. Nociceptive pain is when tissue damage occurs, like getting cut with a knife or burning your hand. Neuropathic pain is when the pain is not associated with significant tissue injury. So people can feel severe pain even when no tissue damage is occurring. It is important to recognize that neuropathic pain is very common once symptoms have entered the chronic pain state of beyond 3 months. Neuropathic pain is often present when pain is constant, when you can't tell what is making the symptoms worse. That is, the symptoms are provoked very unpredictably. When pain is worse at night, and if the pain is starting to affect you emotionally. Some people are more likely to develop chronic pain, and it doesn't depend on who has bad arthritis. It depends actually more on having inherited certain brain chemistries, being overweight, being exposed to whole body vibration, and having a history of depression or anxiety states. So, why the disconnect between anatomy and pain and function? Well, anatomy alone does not predict the degree of pain and function. Just as a computer's hardware alone does not predict how well it works, the software has to work right. Too many open programs, a computer virus, or other glitches create lots of problems that render the computer non-functional. In humans, however, biochemical changes affect how sensitive a nerve ending is. Poor posture and tight muscles or deconditioned muscles allow sensitive structures to be put under abnormal loads. Neurological pain pathways can become hyperactive and generate pain even when the original structure is not being damaged. We see examples of hypersensitive or falsely generated pain in situations like a paper cut, where a tiny sliver of a cut brings so much of our attention, or phantom limb pain, where an amputee can have sensations in a limb that doesn't even exist any longer, or how chalk on a chalkboard can send shudders up our spine that linger far beyond when the sound has stopped. Our emotional state matters greatly as well. When pain is severe and disabling, it creates fear and activity avoidance. This leads to deconditioning, sleep disturbances, change in our brain chemistry, all of which lead to propagation of these abnormal pathways. Patients only feel more invalidated and alone when their friends and their family don't understand, and their doctors can't find a structural problem. So let's spend a little time talking about these pain pathways. This is called the homunculus. Our brains have a map of our body on it. Certain parts of the cerebral cortex correlate with certain body regions. Areas that have a lot of fine-tuned sensibility have larger parts of surface area allocated for it. Now I've talked about how a spine MRI can't tell you who is in chronic pain with any reliability. But now what's interesting that's been discovered over the past decade or so is that special functional tests like an MRI of the brain can tell who is in chronic pain to within 90% accuracy. So this is not to tell you in a derogatory way that the pain is in your head, but in a very biological way, pain pathways can become ingrained in our brains and self-reinforce. The pain causes brain changes. Pain is not only a muscular or skeletal insult, but it is a brain insult. These are functional MRIs of 4 different pain states. They each create patterns of abnormality that are distinct. You can see how patients with chronic back pain have an abnormality in their midbrain and dorsal pons. These are distinct patterns that you can see on functional MRI imaging studies. Changes occur to the brain in chronic hip osteoarthritis. Here are functional MRI imaging showing brain changes consistent with atrophy in patients with chronic hip osteoarthritis. These changes start to revert when the patient has a hip replacement. So hip replacement is a 90% effective intervention. But unfortunately, for other musculoskeletal treatments, most are not nearly as effective. No treatments are 90% effective for very common pain states like neck pain, low back pain, headaches, or fibromyalgia. So we have a much more difficult task. We need to address the problem at every level of this cascade. If the anatomy is correctable, those options should be discussed. Some people with spinal stenosis and herniated discs have a set of symptoms that can be surgically corrected. The biochemical inflammation could be addressed with oral medications and perhaps injections of corticosteroids. The biomechanical deficiencies are addressed with attention to posture and strengthening exercises. The neurological chronic pain pathways are changed with knowledge of this disorder, moderate intensity exercise, good sleep, and cognitive strategies like counseling, cognitive behavioral therapy, mindfulness-based stress reduction programs, and meditation. And lastly, medications can also have an impact on this neurological functioning. The emotional perception of the problem is addressed similarly. The emotional state really matters, and I can't emphasize that enough. So, our program focuses on a lot of these key aspects. We commonly think of exercise as good for our muscles and our heart. However, the benefits of exercise extend far beyond that and help with brain function, pain tolerance, and emotional state. Exercise can actually create new brain cells and new brain pathways. This step is key to undoing those chronic pain pathways that become ingrained in chronic pain states. Exercise can actually help neurological conditions like Alzheimer's and Parkinson's disease. Exercisers have higher pain tolerances. Triathletes usually have higher pain tolerances in various studies that have been conducted. Exercise itself fights pain, and even a single session of exercise improves pain tolerance. So we should try to exercise at least 150 to 180 minutes per week, and the intensity should be at least moderate intensity exercise. It should basically be intense enough that we should not be able to have an easy conversation. You should be able to finish a sentence, but it shouldn't be really easy. The intensity and heart rate guidelines should be per your doctor's recommendations, especially if you have any cardiac history, diabetes, or pulmonary conditions. Some rough guidelines can be estimated based on the formula above. Target heart rate should be around 220 minus the age, and that quantity times 0.7. To move forward, we need to listen to our bodies, but recognize that we have some ingrained thoughts and fears about pain that have undermined our progress. We don't have to think that all pain represents damage. We need to break this cycle of pain followed by activity avoidance, followed by deconditioning, fear, more pain, more activity avoidance. After you work out, you may have more pain. I invite you to try to exercise again and see if we can break this cycle of deconditioning. We need to set realistic goals. Exercise is a key component of your recovery. Recognize that it will improve your muscle mass and decrease fat, improve your emotional state, improve your memory, improve your cardiac function, strength, flexibility, balance, and bone density. Tobacco use can accelerate degenerative disc disease. It is a crutch that one commonly uses to self-medicate anxiety. Stop relying on these addictive drugs that accelerate degenerative disc disease. Many parameters of your life will improve, and although none of this is easy, it will be worth it.